Welcome to the deep dive. Today we're tackling a really interesting question. Could hyperbaric oxygen, or HBO2 as it's known, actually play a role in helping bones heal?
Yeah, it's a fascinating area.
So if you're maybe dealing with a stubborn fracture that just won't mend, or maybe you're just interested in, cutting edge medical possibilities, this could be for you.
Definitely.
Now, HBO2, it's not exactly a standard treatment for fractures right now, is it?
No, not typically for straightforward fractures, but the science behind why it might help.
Hmm.
Well, that's pretty compelling.
And that's what we're diving into. We've been looking at excerpts from the textbook Hyperbaric Medicine Practice, right? Specifically, chapter 24.
Exactly. That chapter focuses specifically on fracture healing and the potential roles for hyperbaric oxygen.
So our mission today really is to unpack that, understand the science, see what the research actually shows, and get a handle on the potential, but also, importantly, the limitations.
Right. Where does it stand?
Okay, so let's start with the basics. How does a bone normally heal? Our bodies are usually pretty good at this, but what are the absolute essentials for that process?
Well, there are really three key ingredients, you could say. First, the fracture site needs good perfusion.
Perfusion, so blood supply.
Exactly. A strong blood supply to bring in nutrients and, crucially, oxygen. That's number one. Second, the broken bone needs proper stabilization. It has to be held steady.
Makes sense, so it's not moving around.
Right, so healing isn't constantly disrupted. And third, you need the right environment for these specific cells, progenitor cells, to actually form new bone.
Okay, so perfusion, stabilization, and the right environment for those cells.
Yeah, and when any of those are missing or, not adequate, that's often when you see problems like delayed healing or what's called non-union, where the bone just doesn't knit back together.
You mentioned an analogy in the chapter comparing it to how soft tissues heal. How does that help us picture bone healing?
It's actually a really helpful comparison because the stages are quite similar. You start with the injury, obviously. Then a hematoma forms. That's basically a blood clot right at the site.
Okay.
That clot kicks off an inflammatory response. Your body sends in the cleanup crew, gets rid of debris, sends out signals, then you get granulation tissue forming.
Kind of like scaffolding.
Sort of, yeah. Then cells grow, forming what's called a soft callus. This gradually mineralizes, hardens into a hard callus that's the new bone being laid down. And finally, the bone remodels itself, reshapes over time back to its original strength and form.
And oxygen is important through all of this.
Critically important. Many of those steps, the cells doing the work, they absolutely depend on having enough oxygen to function properly.
So it's not just helpful, it's like fundamentally required.
Absolutely. And this actually links back to some really foundational research from the 1960s. Dr. Bassett did work showing that these fracture precursor cells, well, they behave differently depending on the oxygen levels.
How so?
In a low oxygen or hypoxic environment, especially with compression, these cells tended to form cartilage. But if you put them in a high oxygen environment, hyperoxic, again with compression, they tended to form bone.
Wow, okay. So oxygen level could literally change what kind of tissue gets made.
That's what his findings suggested. And it really clicks with what we often see in those non-unions we talked about. You often find cartilage and fibrous tissue, not bone, filling the gap. And those tissues are often avascular. They don't have a good blood supply.
So the oxygen level could be a major deciding factor in whether healing goes down the path to bone or gets stuck.
It seems to be a really critical factor, yeah.
Yeah.
A potential fork in the road for the healing process.
That makes a lot of sense. Okay, let's talk about the main cells involved. The chapter mentions osteocytes, osteoblasts, and osteoclasts. What's the job of each one, and do they all need the same amount of oxygen?
Right. Those are the core team. Osteocytes are kind of like the embedded sensors within the bone. They detect stress and strain and help direct the others.
Okay, the managers.
You could say that. Then you have osteoblasts. They're the builders. They lay down the new bone matrix.
Got it.
Builders.
And osteoclasts are the remodelers, or maybe the demolition crew. They break down old or damaged bone. This is essential for reshaping the bone and also for releasing calcium.
So builders and remodelers, do they have different oxygen needs?
Hugely different. This is really striking. Osteoclasts, the remodelers, are incredibly active metabolically. They need something like 100 times more oxygen than the osteoblasts, the builders, to do their job effectively.
100 times?
Yeah.
Seriously?
Yeah. It really highlights why that good blood supply, that perfusion we mentioned first, is so absolutely vital, especially during the remodeling phase when osteoclasts are working hard.
Okay, and that brings us back to stabilization too,
Yeah,
right? It's not just about keeping the bone aligned.
exactly.
It's also about letting these cellular processes happen without disruption, like letting the builders build on a stable foundation. Precisely. If the fracture site is moving too much, it disrupts the delicate scaffolding being laid down, it can damage the new blood vessels trying to grow in, and it just makes it harder for the osteoblast to build properly and for the osteoclast to remodel effectively. It's all interconnected.
And it's a significant problem when it doesn't work. The chapter mentioned about 4.7% of fractures in the U.S. have issues with healing.
Yeah, that's a sobering statistic, nearly 5%. That means a lot of people are dealing with fractures that are slow to heal or become non-unions, which really underlines why we need to explore every potential avenue to help, including things like HBO2.
Okay, so we've got this strong scientific rationale. Oxygen seems critical, especially for certain cells and stages. Let's turn to the lab evidence now. Have animal studies actually back this up? Have researchers seen these effects when they manipulate oxygen levels?
Yes, absolutely. There's quite a long history of animal research looking specifically at this. Even back in 1932, researchers like Ham observed that these bone-forming cells, osteogenic cells, could go either way, bone or cartilage, depending on the local conditions, particularly oxygen.
So this idea isn't new.
Not at all. And consistently, in various animal models, when oxygen supply was compromised, healing was disrupted, and you tended to see cartilage formation, just like in those clinical non-unions.
And what about the role of blood vessels? Angiogenesis, right? Did studies look at that?
Definitely. Several studies, like Collodines in dogs and Gothmans in monkeys, really emphasized that growing new blood vessels into the fracture site was essential for healing. Gothman even showed in a non-union model that if new vessels didn't form quickly, within about 2 weeks, and if the overall blood flow didn't ramp up, healing just wouldn't happen.
So more blood vessels mean more oxygen delivery.
Exactly. And Rhinelander and Bergry found in dogs that deliberately increasing blood flow actually led to bone overgrowth. So good blood supply equals good oxygen equals better bone healing. That's a consistent theme.
Okay, so that's the importance of having oxygen. What happens in animal models when you deliberately limit the oxygen? When you create hypoxia?
Well, as you'd expect based on the theory, the results are generally negative. Studies showed things like increased lactic acid, which isn't good for cells, and decreased production of the actual bone matrix when rat bones were oxygen deprived.
So less building material being made.
Right. And Heppenstall's work in dogs directly showed that tibial fractures in hypoxic conditions had delayed healing. It clearly demonstrates how sensitive the process is to oxygen availability.
Okay, makes sense. So then the flip side,
Right.
what happens when you increase the oxygen using hyperbaric oxygen in these animal studies?
This is where it gets really interesting and mostly positive. Several studies found benefits. Sledge and Dingle saw high oxygen speeding up the breakdown of cartilage and promoting new bone formation.
So clearing the way for bone.
Yeah. Others like Coulson and Ray and Rogers reported more callus formation in rats treated with HBO2.
The callus is that initial bridge of new bone. Right.
Exactly. But they also noted something interesting. Initially, the bone strength was sometimes a bit lower.
Lower? Why would that be?
The thinking is that the HBO2 might have really stimulated those oxygen-hungry osteoclasts, accelerating the remodeling phase. So more breakdown initially as the bone reshapes, leading to a temporary dip in overall strength before it fully consolidates.
Ah, okay, so faster turnover, but maybe a transient weakness.
Potentially. But other studies, like Yablon and Cruz, found that twice-daily HBO2 treatments still led to improved fracture healing overall in rats. It seemed to give the process a boost.
So it seems like a bit of a dynamic process. Faster callus, maybe faster remodeling.
Right, and research by Lornan and Kelly using tracers was pretty dramatic. They found a 6-fold increase in blood flow in dog tibial fractures treated with HBO2.
6 times the blood flow.
Yeah, indicating a huge jump in metabolic activity and oxygen demand, which the HBO2 was presumably helping to meet.
And were there biochemical studies, too, looking at the actual molecules involved?
Yes. Groups like Nienikoski and Pentinen looked at the biochemistry. They found HBO2 stimulated the production of important precursors for healing and mineral deposition, leading to that increased callus. There was even work by Brighton and Krebs on growth plates, suggesting high oxygen promotes a key step in collagen formation, which is crucial for bone matrix.
So, a lot of converging evidence from different angles in animals.
Mostly, yes. But it's important to mention one study by Gray and colleagues that introduced a bit of caution. They found that continuous exposure to HBO2 in mice actually led to decreased bone formation and resorption, even though collagen increased.
Continuous exposure was
That
bad.
seemed potentially detrimental, yeah, which really supports the idea that the benefits might come from intermittent pulses of high oxygen, like the typical HBO2 treatment schedule, rather than just flooding the tissue constantly.
That's a really key distinction. So, summarizing the animal work, it looks like intermittent HBO2 often speeds up callus formation and union, maybe by boosting blood flow and cell activity, but you might see some accelerated remodeling effects, and continuous exposure could be counterproductive.
That's a very good summary. The intermittent pulses seem to be the key, providing that boost when needed without overwhelming the system.
Okay, that makes the rationale even stronger. Now, the big question. How does this translate to humans? We've seen promising signals in the lab. Do we have solid clinical evidence in people with fractures?
Well, this is where it gets a bit more challenging. Unfortunately, the amount of high-quality clinical evidence, especially comparative studies in humans, is much more limited compared to the animal research.
Really? Despite all that animal data?
Yeah, it's often the case that translating lab findings to clinical practice takes time and requires large, rigorous trials, which have been as plentiful specifically for fracture healing with HBO2.
So what kind of human studies have been done? Have they looked at physiology?
Some have. For example, Lindstrom's group measured things like oxygen levels and blood flow in patients with tibial fractures getting HBO2. They saw physiological changes, but the study didn't actually report on the fracture healing outcomes themselves.
So they showed it does increase oxygen, but not whether that helped the bone heal faster in that study.
Correct. And then you have studies like Porcellini's group who used HBO2 in patients with really severe injuries, major vascular damage, along with fractures. But their main goal was infection control and wound healing. So while the fractures were present, the direct effect of HBO2 on the bone healing wasn't the primary thing they were analyzing.
It sounds like maybe a lot of the human evidence comes from individual case reports then.
There are definitely some notable case reports, yes. Braun and colleagues, for instance, described a complex case, a non-union of a neck vertebra, an odontoid fracture that also had wound breakdown. They used HBO2, and interestingly, both the wound healed completely and the non-union finally fused.
That sounds promising, but it's just one case.
Exactly. Very encouraging for that patient. But you can't draw broad conclusions from a single case study.
Right. And what about systematic reviews, those big analyses like the Cochrane reviews that try to pool all the data?
Well, the Cochrane review from 2005 looked specifically at HBO2 for delayed healing and non-union. Their conclusion at the time was pretty clear. There just wasn't enough good quality evidence to either support or refute its use.
So basically, the jury was still out due to lack of strong studies.
Pretty much. They couldn't find enough robust, randomized controlled trials to make a definitive recommendation either way back then.
Okay, that was 2005, though. You mentioned some more recent studies, maybe from China. Has anything changed since then?
There have been some more recent studies that add to the picture. One important one was by Bouchur and colleagues. They did a randomized controlled trial, which is a strong study design specifically in patients with severe crush injuries. These were Gustilo-grade 2B open fractures with vascular compromise, really nasty injuries where blood supply is a huge issue.
Okay, so a very specific high-risk group. What did they find?
They found significantly better healing rates in the group that received HBO2 compared to the control group. They also needed fewer repeat surgeries. That's quite significant for that type of injury.
That does sound significant. And the studies from China?
Yes, a couple more recent ones. Chen looked at children with long bone fractures treated with standard surgery, and the group that also got HBO2 had less pain and swelling, could walk earlier, and healed faster on average. And Chen conducted a randomized controlled study in adults with delayed tibial fracture healing, so non-unions essentially. They found significantly better callus formation and reported a high total effective rate in the HBO2 group.
So these newer studies, particularly targeting severe injuries or delayed healing, seem to be showing more positive results.
They do seem to offer more support, aligning better with the animal data and the underlying theory. It suggests that maybe HBO2 is most beneficial in these more challenging scenarios where oxygen delivery is likely compromised.
So the clinical evidence is maybe still limited overall, but growing and perhaps pointing towards specific applications.
I think that's a fair way to put it. It's not overwhelming yet, but the combination of the known mechanisms, the consistent animal data, and these more recent positive clinical findings, especially in tough cases, does build a case for its potential role.
Okay. Now, the chapter also includes some personal experiences from one of the authors, Dr. Strauss. While we know anecdotes aren't proof, sometimes they offer insights. What did those experiences suggest?
Right, it's important to frame them as observations, not formal evidence. But the author shared several cases involving lower extremity fractures, specifically delayed unions or non-unions, where adding HBO2 seemed to coincide with eventual healing. And these were generally not the typical open fractures or infections where HBO2 might already be considered.
Can you give an example or two?
Sure. There was a mention of 3 active-duty Navy personnel with tibial non-unions after motorcycle accidents. Standard treatments hadn't worked. They had a specific surgery, casting, and HBO2 treatments, and all 3 eventually healed. There were other cases, too. Bilateral femur non-unions that healed after hardware removal, external fixation, and HBO2. A proximal femur non-union healing with HBO2 while the patient couldn't bear weight. And a really severe proximal tibia fracture with major skin loss. In that last one, HBO2 was used alongside multiple surgeries, debridement, grafting, and a flap, and seemed crucial in ultimately saving the limb.
Those sound like really complex situations where maybe everything possible was being thrown at the problem.
Exactly. And that was a key point drawn from these experiences. HBO2 was always used as an adjunct, an add-on to state-of-the-art orthopedic care. It wasn't a replacement for surgery or proper fixation.
So never a standalone treatment. What other themes came out of these anecdotes?
A few interesting observations. One was that giving a course of HBO2 before the main definitive surgery seemed to kind of prepare the tissue, making the fracture site respond better. Staged surgeries with HBO2 before and after also seemed beneficial.
Priming the site almost.
Perhaps. There was also a sense that HBO2 promoted bone formation and, importantly, angiogenesis, new blood vessel growth within bone grafts. Using it early in high-risk fractures seemed supported. And it appeared to promote bone remodeling.
Okay, that remodeling point again.
Yes. And interestingly, there was a note about observing some delayed onset stress fractures after patients started walking again.
Oh, really? Any idea why?
The thought mentioned ties back to what we discussed from the animal studies, that accelerated remodeling might lead to a temporary period where the bone is structurally a bit weaker or different, potentially making it more susceptible to stress fractures when full activity resumes. It's an interesting observation that needs more investigation.
Definitely something to keep in mind. So let's pull back again to the bigger picture. The chapter emphasizes this fundamental principle. Good blood supply and oxygen are crucial for bone health generally, not just fracture healing.
Absolutely. It's a core concept in bone biology. We see evidence for it everywhere. Think about limb overgrowth, sometimes seen in kids after fractures, that's linked to increased blood flow during healing.
That's right.
Or creating an arteriovenous fistula, which dramatically increases blood flow, can cause bone overgrowth, even in conditions like heterotopic ossification bone forming where it shouldn't, or acromegaly. Changes in blood flow and oxygenation seem involved.
And the flip side is also true. When blood supply is lost, bone suffers.
Dramatically so.
Yeah.
That's the basis for conditions like osteonecrosis, bone death. It can happen after certain fractures disrupt vessels, with steroid use, alcoholism, decompression sickness. Lots of causes.
Okay.
You also see it in osteoradionecrosis after radiation damages blood vessels, or that bisphosphonate-related jaw osteonecrosis. Even severe frostbite or infections like purpura fulminans can lead to bone death due to lost blood supply. We even use things like technetium bone scans, specifically to look at blood flow and viability in bone.
It really drives home how dependent bone is on that perfusion-oxygenation link. Now, going back to fractures, the chapter mentioned that roughly 4.7% predictably have delayed healing and listed risk factors. What were some of the big ones?
Yeah, that large review identified quite a few factors that significantly increase the odds of non-union. Things like major soft tissue damage around the break, high-energy trauma, if the bone was shattered into many pieces, comminution, if the fragments were far apart, displacement, contamination like in an open fracture.
Things related to the severity of the injury itself.
Right. Also, anything interrupting the bone's own blood supply and inadequate initial treatment. Certain locations are also tougher. Metatarsals in the foot, the scaphoid in the wrist, tibia fibula femur, they just have higher non-union rates statistically.
What about patient factors?
Open fractures, having blinkable fractures, using both NSAIDs and opioids together, needing surgery in the first place, being on anticoagulants, having osteoporosis, needing insulin for diabetes, and smoking were all significant risk factors.
That's quite a list. Anything surprising?
Maybe 2 things stood out in that specific review. Age, surprisingly, didn't come up as a major independent factor, and there was a lack of specific perfusion data included, which seems like a gap given everything we've discussed.
Interesting. So, with all these risk factors and the known importance of oxygen, is the argument strong for considering HBO2 as an adjunct, maybe to prevent nonunions or treat them?
The chapter suggests it's a reasonable consideration, especially when we use the available tools to guide the decision. Clinical assessment is key feeling pulses, using Doppler, checking skin color, temperature, capillary refill, those basic signs of perfusion.
Looking for signs of poor blood flow.
Exactly. And we can get more objective data with transcutaneous oxygen measurements near the wound or fracture site. The chapter also introduced something called the Wellness Score and Goal Score.
What are those?
They're described as user-friendly tools, detailed elsewhere in the book, to help assess the patient's overall health status and their commitment to saving a limb when facing non-union. If the scores are good, like 5 or more on both, it supports making more aggressive attempts at healing, potentially including HBO2.
So a way to gauge if the patient and the situation are suitable for complex interventions.
Right. And the authors argue that HBO2 seems most justified as an adjunct when you suspect ischemia or hypoxia. Poor blood flow and oxygen are playing a role in a non-union, particularly if the patient has multiple risk factors. Even if prior surgeries failed, if the wellness and goal scores are supportive, trying again with orthopedic procedures plus HBO2 should be considered.
Okay. But there was a caveat about a scoring system.
Yes, the rational-based indications or RBI scoring system for HBO2. When applied specifically to fracture healing within this chapter's context, it only generated a modest score, like 4 out of 10 points. This really just highlights that based on current approved indications and the strongest evidence level, its justification isn't super high yet, reinforcing the need for more targeted research.
Got it. So let's try to wrap this all up. What are the main conclusions we can draw from this deep dive about HBO2 and fracture healing?
I think the key takeaway is this. While HBO2 isn't, a standard approved indication for non-unions across the board right now, the fundamental science, the mechanisms, strongly support considering it when there's good reason to believe poor blood supply and lack of oxygen are part of the problem.
And assessing that involves clinical judgment, maybe oxygen measurements, imaging.
Exactly. Assessing the perfusion is crucial. And tools like those wellness and goal scores can help guide the really tough decisions about limb salvage versus amputation.
So despite the limitations in current large-scale clinical evidence.
Right. Despite that limitation, the lab studies are remarkably consistent about oxygen's vital role. And when you're faced with a non-union, especially after standard treatments haven't worked and amputation's on the table, the chapter makes a strong case that HBO2 should be in the toolkit, considered as an adjunct to other orthopedic techniques. Because ultimately, bone perfusion and oxygenation are always primary factors in whether a fracture heals or not.
So, to summarize for everyone listening, HBO2 seems to hold real promise as a potential helper, an adjunctive therapy, for those really difficult fracture situations, especially if getting enough oxygen to the site is a concern. But clearly, we need more robust clinical research to really nail down its role and best use.
That's the bottom line, yes.
Which definitely makes you think, doesn't it? Given how fundamental oxygen is for tissues to repair themselves, what other conditions, maybe ones we find really intractable right now, might potentially benefit from boosting oxygen delivery in a targeted way? And, what are the hurdles, practical, scientific, economic, to getting therapies like this used more widely if they do prove effective? Lots to ponder there.
Absolutely. Some big questions for the future.
Well, this has been a fascinating deep dive. Thanks for joining us.